Yeah, perfect. Just to very quickly introduce Dr. Kuzani. He is the Deputy Director, Community and Promotive Health Services, CPHS, that is, and the Program Manager of NTLEP Malawi. Today, he's going to be talking about the implementation experience of the chest X-ray and CAD in Malawi's mobile diagnostic unit. Dr. Kuzani, the floor is yours.
Thank you. Can you hear me?
Yes, we can now.
Thank you. I apologize to everyone. I'm so sorry about that. Anyway, can we move on to the next slide? Next slide. So the mobile diagnostic units are a active case finding approach. What brought it about were findings from a prevalence survey that we did back in 2012 through to 2013, and which is the basis for the figures that were reported to WHO in 2014. Anyway, what that found was that we had been missing a lot of TB. We were finding less than 50% of what was possible. And we also found out that lots of people that we had missed were coming to facilities repeatedly, but we were repeatedly missing the opportunity to diagnose them with TB. And from all of that, and these findings about more TB in urban areas, in certain urban areas over rural areas, we devised this, the mobile diagnostic unit. So what you can see is it targets high-risk groups, and those high-risk groups are both in the urban and rural areas. There are a number of them. There are 12 for now, but originally, and this is back in 2018, there were 7, and they were deployed to the hardest hit areas. So when I say deployed, they're deployed permanently to these areas that were hardest hit. Because of the success we had seen with these 7, we then bought an additional 5 in 2023 and deployed these to borders primarily, but they too roamed around the country just like the original 7. Next slide. So what did we do? What we have basically is an approach that blends WHO's 4 symptom questions in parallel, at least originally, with a digital X-ray with a computer-aided diagnostic system that is running on AI. In this case, we're using Delft system. That was the original system we used for these original 7. So we had fixed X-rays in these trucks. We initially set it at 50, then later on at 60, and would have people come through and screen first through questions and then through an X-ray, and then give us a sample if they could. Please take note of that. And that would run on Gene Expert. We didn't want to leave the system completely, how do I put it, unsupervised, in a sense, the decision completely at the mercy or at the hands of the AI. So there was a clinician to verify and to agree. This also gave rise to clinical diagnoses. That too shall play an important role later. Next slide, please. So what did this algorithm look like? So the WHO symptoms, I think you know, they basically cough, fever, night sweats, and weight loss. So for those that we deemed to be high risk, we put this algorithm, this set of questions into categories. For those that we felt were high risk, and you can see who that is. And for anyone else, it made the basis for what we asked. And this is how it was split. So when we're facing minors, people living with HIV, prisoners, healthcare workers, you can see how it was used. It was any cough, it was any fever, it was any night sweats, it was any weight loss. Whereas in other settings, it would be, as you can see on the right, on the chest X-ray side. So who did we target precisely? We targeted urban dwellers in places that we knew to be hotspots. So this was a mixture of basically experience. You're looking at the places that have reported cases and putting them on a map and saying, okay, so we're seeing a lot of cases or a lot of presumptive cases come out of that area. That's a hotspot because we didn't have the means to always do this. So over time, this is a dynamic system taking note of each district's areas that are producing the most cases or producing the most people um, uh, to be examined. Obviously, more space to, we give more credence to more cases from that area, but these are the considerations. So we had urban dwellers and hotspot communities. This especially applied to the rural part of our campaigns. We also targeted people living with HIV. We targeted healthcare workers, industrial workers, so people working at tobacco farms in the tobacco processing industry. We targeted migrants, hence the latter five that were stationed at borders, miners, ex-miners, and the communities around them. We targeted those that were internally displaced. So the last 5 years, I think you are probably aware, have seen what do you call them, cyclones off the coast of Mozambique. Mozambique has been affected the most, unfortunately, but Malawi has also faced some of that, and that's what we mean by internally displaced. So in the southern part of our country, the first part of the year would often see, over the last 4 or 5 years, uh, between February and April, parts of the what we call the lower Shiria, so the southern part of the country, would be inaccessible, flooded, and these vans would help in that kind of response. Others that we targeted were OPD clients, and then we also had periodically screening the biggest prisons. Next slide, please. So originally, our algorithm was in parallel. Started off at 50%, the default for the system. And this is what it looked like. You did TB symptom screening, and you did a chest x-ray. This is the current one, but let me just explain what came before it. So you would have TB symptom screening followed immediately by an x-ray. And then that would be interpreted by the clinician. So what you had was, depending on what the x-ray said or what the screening or what the answer was from the 4 questions, that would determine whether we would ask you for a sample or not. We then switched to a sequential model. Why? Or people would ask. We figured, well, this isn't research. And what we want to know is, do we need to investigate further or not? So we couldn't see a reason why we should continue to do these things in parallel if the the 4 symptom screen already said yes. So we would start with a 4 symptom screen. If it says yes, there's no need for us to do an x-ray. Well, we've gotten the answer we're looking for. We need to screen this person. We need to further investigate this person by collecting additional, by collecting sputum. If it says no, on the other hand, we have an interest in doing the x-ray. And that would be the basis for the question of whether we investigate further or not. So we moved away from, regardless of the situation, of having this one in parallel to this sequential negative. Obviously, with these changes, humans will make their own decisions. They have their own beliefs. And so it takes time to get people to buy into this. I'm basically alluding to a need to continuously remind the colleagues in the field to use this however they feel. This point will become important in my conclusion as to what it is we see. Next slide, please. I've already spoken about this, so next slide. I think we can skip this. We all know this, so let's go to the next slide. So this is what we've been using. This is just to tell the story incomplete, though I'm going to concentrate on the Delft version. That's the one we have way more experience with. It's run from the beginning to date. And so this version is in uh, 9 of the MTUs actually. So even the 5 new ones, 2 of them still run on this, whilst another 3 will run on competitors. We went from a threshold of 50 to 60. We've been running this since 2018. This is the original 7. Um, and we're giving you details as to which one of the vans don't have the CAD. What we're trying to point out is there have been intermittent or there have been points where we haven't had access to the CAD for whatever reason. It might be supply chain shocks, etc. We don't think we should ever rely on CAD alone. We can't, I suppose an argument can be made for doing so, but we think a human element should always be there. We think we should concentrate more on bacteriological, and again, this will become important. There's a strange phenomenon in which if you give a clinician, I suppose if you gave anyone a new shiny toy, that's great. There's an incentive to use it. And that makes up part of what we're seeing. At least that's what we think. I think we'll continue to investigate. Next slide. So how have we performed in that time? Like I said, we started in 2018 and we really started in June of that year. So you notice in 2018, we only screened 119,000 people. Um, and that constituted 45% of what we wanted. We found 14,700 presumptives, and they made up just slightly less than a third. We could only actually examine 9,200 of the 14,700, so about 2/3 were examined. We found 179 cases that were positive on GeneXpert. 3 of those came out with RIF resistance. And then we overall diagnosed 325 cases, which means that there was a lot of people who were diagnosed on the basis of something wrong on the X-ray. And I think this poses a question that I think becomes a problem for TB programs that we'll visit again later. Anyway, so that's what we have in the first year. And this is the year that it's at 50%. You look at the number of people that we're finding with that require examination, and notice that we went from 27, then 16 downwards to 11%. And this is that point we're trying to raise, that we increased the threshold. Now, again, this is an interesting thing about all of this, because if we follow the logic that we're doing all of this to find the missing cases, to find more men, to increase the total percentage, the total proportion of people that we find that are estimated, then logically that figure, that threshold should actually be set lower. You should actually have a lot more people that are being potentially examined or being labeled presumptive. However, this is the thing about reality, about our actual practices. We went from the 50% rather than you think going towards 40 or 30 or what have you, towards 60, reflecting that there are other choke points, there are other limiting factors. And in this particular case, it was the cartridges. The more people you have to examine, the more cartridges you need to use, the more things that it triggers. We couldn't afford what this would have meant, and this is the pragmatism in play. So we went the other way. We know that scientifically, wanting to find more cases, let's go downwards, a lower probability score. But because we're being pragmatic, we're looking at the expenses of these tests. Yes, they're excellent, much better than what we had before, much newer. And what I mean is the GeneXpert. On the other hand, this is balanced by a cost of $7 to $11. That whilst much cheaper than what they'll be if we didn't have the concessionary pricing, is still quite pricey. And it's still something that a TV program such as ours has to think about. So we adjusted it to 60, and that's how you see that the number of people, the proportion that we're examining from those screened falls dramatically. So we go from the 27% down to the 7%, and overall what we have is 11%, is what we find over that the 8 years we've been running this intervention. You see that over the last 5 years, it's been at 7% basically, with a NNS that is quite low compared to other points in time. But I suppose it's increasing, as you can see, and this might well expose the limits of these kind of interventions. At least in our case, not having, to my frustration, maps or areas of the country that are being divided by into certain units, so that we can better track hotspots. And I think we're getting to the limit of this and visiting the same areas. We need to find ways of better tracking geographically where are these hotspots, what should we invest in. Next slide. So this is just to reinforce what I've been speaking of. There have been points where we've had the ability to run experiments and to do this kind of analysis and to see what it is we're missing by setting the probability score at certain points. And this is what we saw. So basically, the lower it is, the more presumptives we have, the more TB cases we should theoretically pick up. So if you take that, if we set it at 60 to 69, we miss out on the 804 presumptives we would have had to examine in 50 to 59. Conversely, though, that's only 2 cases we've missed out on. So this is the balance we're constantly having to fight with. That yes, we find more cases the lower we set it. But conversely, for the expense of the number of people we have to examine to find those 2 cases, is this actually worth it? And that was the question we were hit with when we apply the limits of our own budget to this program. Can we afford the additional costs associated with finding one more case? So 402 additional people, that's 402 potentially additional gene expert examinations that have to be done only to find one case. Can we actually afford that? And at that point in time, we couldn't. I still believe we can't now. So we've maintained the 60. And you can see why. We think incrementally we haven't lost as much. And I've already admitted that we do know what the theory is, that we know in a perfect world we should set this lower. But given that we're constrained by real world issues like budgets, we feel that losing 2 whilst losing 401 examinations for every one case we find isn't a bad trade-off. Over. Now, next slide. I think this basically says the same thing, but maybe does it in even more stark fashion. But it's precisely the same thing. It rehashes the same argument that the lower we set it, the better it is. But at what cost, I guess, is what we all have to think about. As for us, we find that we can't afford at this moment in time to set this sub 50%, to set this below 50% and what it means. Next slide. We have done that so before you move on, we have done it in campaigns. That's when we've been able to see some of these figures, what we would have gotten had we set them much lower. So we have run our own experiments that have allowed us to see what are we missing out on. But we remain at this point in time. We will stick with the threshold of 60. One of the interesting things we find is in vans that don't have, so those two vans that didn't have, that for a long time didn't have um, a digital X-ray. It's portable rather than the fixed variety that came originally, but essentially running the same kind of the logic framework, as it were. We find that the proportion that are bacteriologically confirmed, the proportion that is clinically diagnosed, falls dramatically. So you find that those vans have a higher proportion of those that are bacteriologically confirmed. And this, I think, goes back to at this point in time, we're tempted to think that this is simply one of those effects of having a tool to use. If you give someone a tool to use, they will use it. And having seen um, a tool that is trusted like this flag that this area could be TB, they are um, tempted to then diagnose such people as having TB. After all, the goal is to find as many cases. We are pitting people against each other. As you know, competition brings out the best in people and their results. But in doing all of that, it also incentivizes the use of um, X-ray as a diagnostic. We often forget that it's being used as a screening tool, not as a diagnostic. But because it's there, you see this rise in clinical cases. I personally feel conflicted by this. On the one hand, as a TB manager, you could ask yourself, isn't this a good problem to have? On the other hand, is this fair to my patients? After all, this is a screening program. Is it fair? Would I accept as I feel today, and I feel like I'm normal, that on the basis of an X-ray that I just so happen to have on that day, and there's nothing else wrong with me, that I be started on TB treatment. I think this is problematic in um, the sense of a screening program, and we intend to double down on stopping this because they are otherwise well. So I don't think it's necessarily fair. Then there's also the part about the rate, as at least of TB in this country, as um, estimated by WHO, has fallen by 43% over that same period in time, from 197 to 113. So in that context, that we're actually quite low, we're finding people at an earlier stage. Should we be putting people on clinical treatment, on treatment from a screening program? In other ways, well, people on the basis of X-ray? I don't believe so. Next slide. One of the upsides of this, though, has been its effect on men. Um, I don't know how many of you might be familiar with discussions that are happening in the SADC region, and I think the EXA region, so member states from those two areas, have run in recent years programs that are about minors, but have also been linked to missing cases and men. And so one of the things about this program, unlike the routine program that finds a lot more women engaged with the routine program than males, this one, the split is closer to 50-50. And unlike the routine program that sees a two-thirds split, so two-thirds of those we treat are male, whilst one-third of those that we examine are male. So clearly the problem is in males. In this one, it's even more extreme. Now, um, others might think this is bad, that it's three-quarters are actually male, that of the people that are linked to this program are males that we treat, also a quarter female. I think it underscores just how much of a problem we have amongst males and how these um, mobile diagnostic units can be used to attend to that problem, to deal with that problem, to start to deal with that problem. If you consider that the mining industry and industrial output as a whole in most places are male-dominated fields, and by having these, we have to deal with male problems more so than female problems. We still have a problem of their engagement. We found that they prioritize making money over engaging with this, but it still gives us an avenue by which we can deal with males, and we can deal with them on multiple fronts. over. Next slide, please. So what have we learned? There's no doubt that chest X-ray plus CAD improves the efficiency and effectiveness of TB screening. We find that we can find more presumptive TB cases. It can be a useful tool for improving the skills of clinicians who engage with it meaningfully. We found more cases are diagnosed from fewer clients. It is way more efficient than using just the TB, the WHO 4 symptom screening questions. This cuts out the chaff, as it were. But conversely, like I've said, if you give a clinician a new toy to play with, they will play with it. And so it conversely increases clinically diagnosed. We, on the other hand, need to diagnose, we need to reinforce our algorithm. There's a conflation of X-ray as a diagnostic tool. People keep on forgetting that it's being used to simply answer, should we examine further or not? Not should we treat? That's not the question. That's for the gene expert. So we need to double down on this, on explaining that to, and convincing our colleagues to understand that reasoning. A higher threshold, like I've already shown, lowers the cost of the program, but there is a cost. The question is, can you live with that cost? As if you're being pragmatic, we need to create EQA systems that look at this algorithm and adherence to it. We would like to see more geographical mapping of hotspots. We already have it. We'll show it on the next screen. Next slide. This is what we have in mind. We're with our partners, MLW, so they are an offshoot between the LSTM in Liverpool, the Liverpool School of Tropical Medicine, and the Kamuzu University of Health Sciences. And basically, they've been able to map out in red the presumptives and green the cases. And therefore, we could start to build up a map of where the hotspots are. This one pertains to Blantyre. Next slide. Next slide. The same things, just what we could potentially do with it and what it means for us overall. Thank you for your attention. Over.